Welcome to the University of Kentucky Department of Anesthesiology's YouTube channel. This video cast is on anesthesia pharmacology and specifically covers the key words on the 2018 in-training exam. My name is Randy Schell. Let's first look at the key words from 2018 related to pharmacology. I've divided them up into the major categories of local anesthetics, neuromuscular blocking agents, opioids, inhaled anesthetics, and some miscellaneous topics. Under local anesthetics, you can see metabolism of local anesthetics. The B stands for the basic exam content outline. A stands for the advanced exam content outline. Metabolism of esters in the blood with esterases, acetylcholinesterase. Liposuction in the solution that's used there, very dilute local anesthetic and dilute epinephrine. Neuromuscular blocking agents, the receptor anatomy of the nicotinic cholinergic receptor, what succinylcholine does to potassium. Butyrylcholinesterase or acetylcholinesterase, what it acts on. Donepezil or Aricept and some of its anesthetic interactions. These extrajunctional acetylcholine receptors and the problems that we can get into when they are present. Amyotrophic lateral sclerosis, or ALS, and the interaction of this disease with neuromuscular blocking agents. Lithium and how it can prolong neuromuscular blockade, both succinylcholine and rocuronium, as well as reduce MAC. The recovery patterns of neuromuscular blockade, myasthenia gravis and treatment with pyridostigmine, opioids, how they're broken down, what happens with renal failure, problems with seizures potentially, how it can reduce seizure threshold, some of the metabolites of morphine. And under inhaled anesthetics, how they work through protein interactions, stages of anesthesia, 1 through 4, MAC, many factors affecting them, blood gas coefficient and how it affects FA over FI or uptake, and CO is carbon monoxide, and how it can be formed with desflurane and isoflurane for that matter, breakdown in the CO2 absorbent. Misfilled vaporizers, if you could pour the wrong liquid in the vaporizer that doesn't match it, and what would happen. And then some miscellaneous topics like nerve gases, drugs that prolong the QT interval, the anticholinergic glycopyrrolate and its side effects, nausea treatment, diuretics where they work, and some of the side effects, including acetazolamide or Diamox and its effect on ion concentration. It causes bicarbonuria, that is, excretion of bicarbonate in the urine. If you want a complete and comprehensive keyword review over about the last decade of keywords, our YouTube channel has a 3-part series with the addresses listed here, Pharmacology Review 1, 2, and 3. But let's go right into our 2018 keywords now. First is local anesthetics, metabolism. There are amides and ester types of local anesthetics. The amides have 2 I's in the name, lidocaine and bupivacaine are examples, while esters have 1 I in the name, cocaine and tetracaine and chloroprocaine are examples of esters. The esters are broken down very rapidly in the plasma by acetylcholinesterase and other esterases, and one of the metabolic products is pyraminobenzoic acid, or PABA, which tends to increase the allergic risk of esters as opposed to amides. Chloroprocaine is considered safer when there is OB fetal distress because the chloroprocaine has less placental transfer. It's broken down very rapidly in the plasma. And if it was administered in the epidural space and systemic levels started to rise, the blood would break it down very fast and it does not get trapped in the fetus. If you have an abnormal acetylcholinesterase enzyme where the dibucane number is less than 60 to 80, that acetylcholinesterase, which normally breaks down local anesthetics, isn't going to work very well, and the local anesthetics could have a prolonged effect. Now, amides are broken down in the liver by the P450 system, and on the bottom right shows the esters being hydrolyzed in the plasma, as opposed to the amides undergoing multiple different reactions, including hydroxylation, conjugation, hydrolysis, and other things in the liver. So, if a local anesthetic gets into the blood systemically, your liver has to chug away and chew it up, And so amide systemic toxicity is expected to be higher than would be ester systemic toxicity. And if your liver's not working so well, it's not going to break it down, and that's going to increase the risk of systemic toxicity. Another important point about amides, especially bupivacaine, is that if it goes from, for example, the epidural space systemically and then gets into an acidotic fetus during the time of delivery, the fetus, because it's more acidotic and has more hydrogen ions, protonates that local anesthetic, and then it becomes trapped and cannot pass back into the mother. That's called ion trapping, and the buildup of bupivacaine can occur in the fetus. Another important point is the effect of age on metabolism. The very young and elderly tend to have a decreased clearance and may have increased absorption. These factors can result in increased systemic toxicity in the very young and the elderly. Our next keyword is liposuction and the solution that's used, local anesthetic, for liposuction. The picture at the top right shows a tumescent liposuction technique in which a large volume of dilute local anesthetic containing epinephrine is injected into the fat tissue, which breaks up the fat. The lidocaine provides the analgesia, and the epinephrine provides the vasoconstriction to reduce blood loss and to reduce absorption of the local anesthetic. Now, what is that solution made up of? Very dilute lidocaine, 0.025 to 0.1%, and very dilute epinephrine, about 1 to 1 million. 1 to 200,000, which we characteristically use with regional anesthesia, has 5 mics per mil. So this solution only has a 1 mic per mil. The maximal dose of lidocaine is usually considered to be 3 to 4 milligrams per kilogram when administered without epinephrine subcutaneously, and 7 milligrams per kilogram when lidocaine is administered subcutaneously with epinephrine. But look at the doses here that are used with liposuction, 35 to 55 milligrams per kilogram, although there's recent expert opinion that puts that maximal dose at about 45 milligrams per kilogram. Why don't we get systemic toxicity? Because there's low blood flow to the adipose tissue. The epinephrine provides vasoconstriction, reducing the absorption, and there is sequestration of the lidocaine in the fat, such that peak lidocaine levels occur about 12 to 14 hours after injection and then decline over the next half a day or so. You may have signs of local anesthetic toxicity, such as tinnitus, ringing in your ear, circumoral numbness, and even progressing to sedation and mental status changes and seizures. It's recommended that you not do large volume liposuction in an office-based setting, and there is mortality associated with liposuction, not only from systemic levels of local anesthetic, but pulmonary embolism, fat embolism, blood loss, and what we were talking about here, which is toxicity, potentially, of the local anesthetic. So local anesthetic solution is a very dilute lidocaine with epinephrine with a maximal dose, recent expert opinion, of 45 milligrams per kilogram. Let's move on to neuromuscular junction cholinergic receptor anatomy now. And we'll start with the presynaptic area. As a nerve signal comes down, you have acetate and choline with acetylcholine little vesicles sitting presynaptically ready to be released. But calcium has to come in presynaptically. And magnesium inhibits this. So up on OB, high doses of magnesium being administered to a parturient can result in weakness. Hypocalcemia, conversely, can potentiate neuromuscular blockade. Hypercalcemia can make a person resistant to neuromuscular blocking agents. Postjunctionally is the nicotinic cholinergic receptor, which is where acetylcholine binds. Now those little presynaptic vesicles have to be released, cross the junction, and bind to that 5-protein subunit nicotinic cholinergic receptor. The 2 alpha subunits of that 5-protein subunit are especially important. That's where succinylcholine binds, that's where rocuronium binds, that's where acetylcholine binds, and causes the channel, the nicotinic cholinergic receptor channel, to open, sodium to go in, and potassium to go out. several important points. Again, calcium is needed presynaptically for the acetylcholine to be released. In the case of toxins like botulism and tetanus, they work presynaptically to reduce acetylcholine release. Now, acetylcholinesterase, the enzyme that breaks down acetylcholine, is present in the postjunctional membrane. Clinically, if we give succinylcholine to a patient, it goes into the blood and is very rapidly chewed up by pseudocholinesterase, the plasma enzyme that breaks down succinylcholine, before it even gets to the neuromuscular junction. But once it's there, it binds, opens it, and sodium goes in, potassium goes out. You have fasciculations and then neuromuscular blockade. Sux has to diffuse away from the neuromuscular junction to be terminated in the plasma by pseudocholinesterase. Train of 4 is a decreased release of presynaptic acetylcholine when you have repetitive stimulation, and we know that extrajunctional receptors can grow instead of just at the opposite side of a postjunctional membrane. They can grow all over a muscle membrane. In the picture on the bottom right, you can see muscle fibers with axon terminals innervating that muscle, and only underneath those axon terminals should be those postjunctional receptors. But in the case of upper motor neuron, lower motor neuron, bed rest conditions, chronic exposure to neuromuscular blocking agents, and burns, we know that extrajunctional receptors can grow all over that muscle membrane and cause problems if succinylcholine is administered to a patient. So, the receptor is a 5-protein subunit with the 2 alpha subunits being the binding site for our neuromuscular blocking agents. The next topic is succinylcholine, potassium effects, and ALS, or amyotrophic lateral sclerosis, and neuromuscular blocking agent interactions. Succinylcholine is contraindicated when there is upper or lower motor neuron diseases, muscular dystrophy, MH history, burns, Guillain-Barré, and amyotrophic lateral sclerosis is a progressive neurologic disease in which if succinylcholine is administered to that patient, they can have lots of extrajunctional receptors that bind succinylcholine, open up, sodium goes in and potassium goes out, and as the picture shows on the far right, if there's all of these extrajunctional receptors in denervated muscle, the potassium rises very rapidly and can cause cardiac arrest. Amyotrophic lateral sclerosis is a progressive neurologic disease with damage to both upper and lower motor neurons, and succinylcholine would be contraindicated. Now, succinylcholine is not contraindicated in renal failure or liver failure. In that renal failure patient, assuming that they don't already have a potassium elevated, you can use succinylcholine and you'll get the usual increase in potassium of about 0.5 milliequivalents per liter that occurs when it's given to patients with or without renal failure. It's also not contraindicated in the static neurologic disease, cerebral palsy. It's technically not contraindicated in open eye injury, although it can increase intraocular pressure slightly and temporarily, and we usually avoid it. It's also not contraindicated in the cases of increased intracranial pressure, although we may reach for other neuromuscular blocking agents in this situation. If RSI is needed, rocuronium is often utilized, but if you use adequate doses of induction agents, this slight increase in intracranial pressure that occurs with succinylcholine probably is not of much clinical significance. Let's move on now to butyrylcholinesterase substrates. Butyrylcholinesterase, the other name for that is pseudocholinesterase or plasmacholinesterase or false cholinesterase. This enzyme is made in the liver and it circulates in the plasma. It is structurally and functionally quite a lot like acetylcholinesterase, such that neostigmine actually inhibits pseudocholinesterase, as does Donepezil, the drug that is used for Alzheimer's dementia, another name for Aricept, which neostigmine and Donepezil are used to inhibit acetylcholinesterase, but they also cross over and inhibit pseudocholinesterase. Dibucaine is an amide local anesthetic that normally inhibits this pseudocholinesterase enzyme about 80%. And the substrates for pseudocholinesterase or butyrylcholinesterase are succinylcholine. It breaks it down to succinylmonocholine and choline, and the duration of action of succinylcholine is affected by the quantity and quality of butyrylcholinesterase in the plasma. Butyrylcholinesterase or pseudocholinesterase also breaks down ester local anesthetics like chloroprocaine, and it also acts on mivacurium. Now, remifentanil and esmolol are not dependent upon pseudocholinesterase for their metabolism. Remifentanil is broken down by nonspecific esterases, which many are present in our body. Esmolol is broken down by RBC esterases with a half-life of about 8 minutes or so, and they are not a substrate for pseudocholinesterase. The next topic is Donepezil and anesthesia interactions, which happen to be a gap in knowledge on the in-training exam of 2018. That gap was that a prolongation of the duration of action of succinylcholine can occur in patients who are taking Donepezil, and this was missed by more than 50% of CA3 residents in the United States. Donepezil, or Aricept, inhibits acetylcholinesterase, and it is a central inhibitor of acetylcholinesterase. Our neostigmine does not cross the blood-brain barrier. Physostigmine, or antilirium, does cross the blood-brain barrier and is used to treat central anticholinergic syndrome. So Donepezil is designed to inhibit acetylcholinesterase centrally, raise acetylcholine levels in the brains of patients with Alzheimer's dementia, and hopefully reduce the symptoms of Alzheimer's dementia. The problem with anesthesia is that it can interact with our neuromuscular blocking agents. Remember that acetylcholinesterase and pseudocholinesterase have similar looks. In other words, many of the drugs that inhibit one can inhibit the other. In the case of Donepezil, which inhibits acetylcholinesterase, it can cross over and also inhibit pseudocholinesterase, the enzyme that breaks succinylcholine down. So if pseudocholinesterase is not working so well and we give succinylcholine to this person taking Aricept, they may have a prolonged duration of action of succinylcholine, but it's usually less than 1 hour. Non-depolarizers like rocuronium and vecuronium, there may be a requirement for higher doses. Why would that be? Because if Donepezil blocks not only central but some peripheral action of acetylcholinesterase and raises acetylcholine levels in the postjunctional membrane, rocuronium and vecuronium are competing with acetylcholine. Now they have to compete with more acetylcholine, and we may have to give more rocuronium to get the same effect. The manufacturer actually recommends that Donepezil be withheld at least 2 weeks prior to scheduled operations. Next topic is extrajunctional acetylcholine receptors. These receptors that proliferate beyond just the neuromuscular junction and out onto muscle membranes in situations of upper and lower motor neuron diseases, muscle diseases, prolonged bed rest, administration of neuromuscular blocking agents for long periods of time, and burns. Now, these extrajunctional acetylcholine receptors, when they are activated, for example with succinylcholine administration, in the picture at the top right shows these little receptors present all over that denervated muscle, and succinylcholine comes in, binds to them, opens them up, sodium goes in and potassium goes out, and they stay open longer and they release a lot of potassium, and hyperkalemic arrest can occur. If a hyperkalemic arrest occurred, you would treat that patient with ABCs, airway, breathing, and circulation, but specific treatment would be calcium, alkalinization, hyperventilation to drive potassium into the cell, insulin and glucose, and inhaled beta agonists, which also drive potassium into the cell. These little subunits have one protein different than does the normal acetylcholine nicotinic cholinergic receptor, and it's represented on the bottom right in red. So one subunit different, and because of that, it tends to have a short half-life and it tends to stay open a little bit longer, and these extrajunctional receptors get us into trouble when potassium goes out, when succinylcholine is administered, and rises to the point of causing cardiac arrest. Sux-induced hyperkalemia, there are two major categories. The one that we've talked about, upregulation of these receptors all over the muscle, and another of rhabdomyolysis, which can occur with muscular dystrophy when Sux is administered. So these myopathies where the muscle is a problem and you give Sux to, there can be massive potassium efflux and breakdown of muscle, rhabdomyolysis, and the urine has myoglobin in it, and it turns brown, and potassium goes up, and cardiac arrest can occur. The next topic is myasthenia gravis, pharmacologic treatment. The one pharmacologic main treatment for myasthenia gravis is pyridostigmine, but let's look at the top right graphic first. And that shows neuromuscular junction disorders and where they act. And we're going to start with Eaton-Lambert, which starts in the presynaptic membrane, and it's a problem with presynaptic release of acetylcholine because of dysfunctional calcium channels. So think of this person with lung cancer, Eaton-Lambert syndrome, where they get stronger when they exercise, as opposed to myasthenia, where they get weaker when they exercise. And the problem is presynaptic release of acetylcholine, and they tend to be sensitive to both succinylcholine and non-depolarizers. Staying in that presynaptic membrane, you can see that aminoglycoside antibiotics also can cause a change in the way that our neuromuscular blocking agents act. In fact, gentamicin can potentiate non-depolarizer neuromuscular blockade. Cephalosporins and penicillins do not. And then botulism toxin and also tetanus toxin acts presynaptically to reduce the release of these little vesicles of acetylcholine, coalescing and releasing it into the synaptic cleft. That's their site of action. Now, myasthenia gravis, the site of action is the postjunctional receptors, which there's an immunologic, often antibodies against them. We don't have as many postjunctional receptors, those patients that have myasthenia gravis. And if we can raise acetylcholine levels with pyridostigmine inhibition of pseudocholinesterase and acetylcholinesterase specifically, we can raise acetylcholine levels and the patient will be stronger. Other treatments for myasthenia include thymectomy, plasmapheresis, and of interest, myasthenia gravis patients tend to be resistant to succinylcholine. There's just not a lot of those postjunctional membranes present for succinylcholine to bind to open, to cause fasciculations, followed by muscle paralysis. But they tend to be very sensitive to rocuronium and vecuronium because there's not many postjunctional membranes that rocuronium and vecuronium have to compete with to cause neuromuscular blockade. So the disease of myasthenia gravis is postjunctional receptor, as opposed to myotonic dystrophy, which is a disease of the muscle itself, where there's slow relaxation of the muscle and they have contractures. If we give succinylcholine to these patients, they could have fasciculations and contractures of a lot of their muscles all over their body, and even ventilation can become very difficult. The response to non-depolarizers tends to be normal, however, and if someone had contractures all over their body from a myotonic dystrophy episode, realize that the disease is in the muscle, and therefore administering rocuronium will not relax those muscles because the disease is not of the neuromuscular junction like it is in myasthenia gravis. The next topic is neuromuscular blockade recovery. That was the key word. Major point is that we really need a train of 4 greater than 0.9 so that the patient in the recovery time will not have impairment in swallowing and potential laryngeal aspiration, because this has been observed, swallowing problems and aspiration, when the train of 4 ratios are less than this number. We used to say 0.7 was an adequate ratio. Now we realize that 0.9 is what we should look for. We cannot see that with our eyes. We need some better form of accelerometer or something like that to be able to compare the first twitch to the last twitch and say, aha, that last twitch is now 90% or more of the height of the first twitch. Just being able to lift your head up for 5 seconds doesn't guarantee that train of 4 greater than 0.9. Ability to hold a tongue depressor between your teeth like in the recovery room, and that tongue depressor is put between the teeth, the patient's asked to bite down, and if you can't pull it out, it tends to be pretty close to 0.9. But again, an accelerometer is the way to really tell, have we reached a train of 4 greater than 0.9? Fade or decreased train of 4 occurs, as you know, with residual neuromuscular blockade with non-depolarizers. It also can occur with a phase 2 block when high doses of succinylcholine are administered. This is very rare anymore because Succinylcholine infusions are not used much. And a fade or decreased train of flow can occur with myasthenia gravis. We don't see fade with myasthenic syndrome. Remember, myasthenic syndrome, as you exercised a muscle, it got stronger. We don't also see it with magnesium or the aminoglycoside antibiotics, or a phase 1 depolarizing block of succinylcholine does not have fade. Monitoring recovery should be done at the ulnar nerve and twitch of the adductor pollicis, shown at the bottom right. Why? Because the adductor pollicis, ulnar nerve, is the last to recover, as opposed to the facial nerve, which tends to recover quicker. So if you want to know if everything's recovered, all the muscles in the body, especially the diaphragm, go to the ulnar nerve, monitor the adductor pollicis rather than the facial nerve. The next key word is lithium anesthesia interactions. And lithium can potentiate non-depolarizers and depolarizing neuromuscular blockade. And it also decreases MAC. That's the major important point of lithium. Someone who's bipolar takes lithium, comes to surgery, realize that succinylcholine and rocuronium can be potentiated, and that our inhaled volatile anesthetic concentrations to keep a patient from not moving to incision will be reduced. Other things that potentiate neuromuscular blockade are inhaled anesthetics, DES, SIVO, and ISO. They are much more potentiators of neuromuscular blockade than our intravenous anesthetics, nitrous, opioids. Magnesium, we've already talked about, has a pre-junctional effect, decreasing acetylcholine release, and does potentiate non-depolarizers and depolarizers. And there's antibiotics. We pointed out aminoglycosides, presynaptic effect, but tetracycline, clindamycin, bacitracin, but not penicillin, cephalosporins will potentiate neuromuscular blockade. Calcium channel blockers potentiate it. And the last point is that if you use two different classes of neuromuscular blocking agents, one after the other, together, you can get synergism if they're in the same class. That is, rocuronium and cisatracurium would be a different class. Rocuronium is a steroid, cisatracurium is a benzyl isoquinoline, so these are different classes. You'll get synergism, as opposed to rocuronium and vecuronium, which are both steroidal molecules, the same class, and you'll get an additive effect. Meperidine in renal failure and morphine metabolites is the next key word. Important point to remember is that if you're just giving a single dose of morphine to someone, we don't worry so much about alteration in disposition of the metabolites or buildup of those metabolites. But when we chronically administer an opioid to a patient, if they have renal failure, they can build up metabolites. And in case of morphine, when it's administered, the liver puts a sugar on the 6th position, morphine 6-glucuronide, in the 3 position, so that your kidneys can get rid of it. The 6-glucuronide metabolite can build up, especially, and has potent analgesic and sedative effects. So repetitive doses of morphine to a patient with renal failure, the 6-glucuronide can get us into problems with a buildup of this metabolite that can cause sedation. And like meperidine, morphine's not a great chronic administration choice in a patient with renal failure. Meperidine has the product normoperidine that is a metabolite, and that normoperidine is neurotoxic and can cause seizures. Dilaudid is metabolized to a glucuronide in the 3 position, hydromorphone 3-glucuronide, and that's an active metabolite and can cause central nervous system excitation. Codeine can cause prolonged narcosis, isn't recommended. Fentanyl is pretty good. Remifentanil is great because you don't need a kidney or a liver to break down remifentanil, and renal failure has no effect on its clearance, but we still will decrease its dose if it was an elderly patient. Another take-home point is that opioid doses are reduced about 50% in elderly patients because they're more pharmacodynamically sensitive. And methadone is considered relatively safe. So up at the top right is some recommendations for opioids in renal failure. Again, codeine not recommended, morphine is not recommended, and meperidine is not recommended due to the metabolites. Metabolism of remifentanil, another metabolic interesting opioid topic because remifentanil is metabolized independent of renal or hepatic failure and is metabolized by nonspecific plasma and tissue esterases. So it doesn't need a kidney or a liver to break it down. It has a potency similar to fentanyl, about 100 times as potent as morphine. It has a little bit more rapid onset than does fentanyl. It effect site equilibration is about 1.1 minute, fentanyl about 6.4 minutes. So when you give remifentanil, fast onset. If you want fentanyl to be acting, you need to give it at least 5 minutes or so from the time you give it for it to be having its onset. Again, if you give remifentanil to a patient, it is the plasma and tissue esterases that are breaking it down, not the kidney or the liver. And even if they have an abnormal butyrylcholinesterase, which is the same as pseudocholinesterase, for example, they had a dibucane number of 20. Dibucane normally inhibits pseudocholinesterase 80%. If someone had a homozygous atypical pseudocholinesterase with a dibucane number of 20, it's not going to have any effect on Remi metabolism. We can infuse remifentanil for long periods of time, 2 hours, 4 hours, 8 hours, and shut it off, and the context-sensitive half-time doesn't change much, about 4 minutes. Interestingly, it is associated with hyperalgesia when it's used in the perioperative period. That is, maybe it's fast onset and fast offset has something to do with this hyperalgesic effect. Opioids metabolism, another interesting point is that opioids, some are a prodrug that must be metabolized to an active form, and codeine is one of those. It is metabolized by the CYP2D6 cytochrome system to morphine. And those who do not have a normal CYP2D6 enzyme, codeine would be like giving water to them because it would not be metabolized to morphine. There are other opioids that must be bioactivated other than just codeine to morphine. Tramadol, oxycodone to oxymorphone, hydrocodone to hydromorphone. So this enzyme is very important. It actually acts on about a fourth of all of our drugs, including things like SSRIs and TCAs and beta blockers and opiates. And as many as 7% of Caucasians have a defective gene, and when you give them some of these opioids, they can have hypoalgesia due to poor metabolism or bioactivation of the opioid. So on the far right is opioids and opioid metabolism, showing codeine in the red arrow going to morphine, requiring the CYP2D6 enzyme, which is defective in many people. The next key word is opioids and seizure threshold. Fentanyl can lower the seizure threshold, but let's broaden the topic just a bit and look at opioids' effect on the electroencephalogram, SSEPs, and in general, the opioid effect on SSEP signals is minimal. And when you look at your BIS, when you're using high doses of opioids, BIS isn't a great monitor of anesthetic depth in an opioid-based anesthetic because opioids don't have the classic effect of, such as propofol or our volatile anesthetics, of an EEG in a wake state going from a high frequency, low amplitude to a low frequency, high amplitude state, and eventually burst suppression. Opioids don't do that. And so if they don't have that characteristic effect on the EEG, they're not going to have the characteristic effect on a processed EEG, and the BIS isn't going to go down as much, even though the patient may be blitzed on drugs like ketamine, opioid, and nitrous oxide, which don't have the classic BIS effect. Very high doses are associated with some slowing of the EEG and delta wave activity. They do not produce evidence of seizures on the electroencephalogram. The one exception, as we talked about, was the meperidine and its metabolic breakdown product in patients with renal failure, normoperidine, which can cause seizures. Opioid tolerance and signs of such is the next key word. Physical dependence, let's define that first. That's where you will withdraw if there's an abrupt cessation of a drug. So rapid dose reduction or abrupt cessation, there is withdrawal symptoms. That's physical dependence. Tolerance is when you adapt to the exposure of the drug such that you have less and less effects of the drug over time. They don't work as well, or it takes more and more of a drug to have an effect. And the signs of that with opioids would be that despite the fact that you're giving the same amount of an opioid to a patient with pain, it's not working as well. And they have more autonomic responses indicative of pain, like tachycardia or hypertension, despite that you're giving that same dose of opioid. That would be tolerance. Addiction, the definition is loss of control over your drug use, uncontrollable compulsion to use despite harm and craving. And we know that fentanyl is the bad actor when it comes to drug abuse in anesthesiologists. MAC and factors affecting. MAC is highest at age 6 months. It peaks there, but there are lots of things that affect MAC, both increase and decrease it. Things that increase it first. Anything that increases central neurotransmitters. Acute amphetamine use. If you're taking speed acutely, it ramps up your neurotransmitters in your brain. It takes more inhaled volatile anesthetic to keep you from moving to incision. MAOIs, monoamine oxidase inhibitors, increase central neurotransmitters. Being hot, hyperthermia, chronic ethanol use, and hypernatremia are all associated with increasing MAC. Things that decrease MAC, as we get old, if we're cold, pregnant, we're acutely intoxicated with alcohol, or any other anesthetics are administered like fentanyl, midazolam, dexmedetomidine, or propofol. And as we pointed out earlier, lithium decreases MAC. MAC correlates, interestingly, with solubility in olive oil. This is not blood gas solubility, because blood gas solubility correlates with the onset of the anesthetic state, or the rise of alveolar over inspired concentration, or the speed of onset. We know that low blood gas solubility is associated with fast onset. MAC is correlated with the solubility of a volatile anesthetic in olive oil. The more soluble, the more potent it tends to be. We know that MAC decreases with age, about 6% per decade after age 40. And that there are some definitions of MAC, including MAC bar, which is block autonomic response. It takes about 1.5 MAC to block that rise in norepinephrine autonomic response that would occur in about 50% of patients without 1.5 MAC on board. MAC awake being 0.3 times MAC, and at 1.3 times MAC, about 95% of patients won't move to an incision. Meyer-Overton principle referred to that the more lipid-soluble an agent tended to be, the more potent it tended to be. And there's this correlation between lipid solubility and potency suggested that maybe there was a single mode of action of volatile anesthetics. And let's not confuse the mode of action of volatile anesthetics and their site of action, which really is proteins in membranes and receptors, rather than just the lipid membrane unitary hypothesis that was discussed many years ago. And that was a gap in knowledge, actually, on the in-training exam 2018, inhaled anesthetics and the mechanism of action. That inhalational general anesthetics do exert their effects by binding to amphiphilic cavities. Amphiphilic refers to hydrophilic and lipophilic properties of those cavities in proteins. So the target of our volatile anesthetics is proteins. That lipid hypothesis, unitary hypothesis, isn't true, and that Meyer-Overton correlation between lipid solubility and potency does not allow us to say, aha, there's only one mechanism, and that's the lipid membrane of where volatile anesthetics work. We pointed out that potency does correlate with solubility in olive oil, but interestingly, although we know that it is the proteins that interact with our volatile anesthetics, shown in the picture on the bottom right, the blue being the general anesthetic molecule coming into a protein, affecting it and causing ion fluxes. These proteins can control multiple different ions, and there is no single mechanism currently responsible for all anesthetic effects. Let's move on to vaporizer filling air. What do you need to know about a volatile anesthetic being put in the wrong vaporizer? Well, the first is the vapor pressure of inhaled anesthetics, and the next is MAC. Let's look at vapor pressure of inhaled anesthetics. This determines the percent delivered from the vaporizer. And vapor pressure is proportional to temperature. As you heat up that liquid, the vapor pressure goes up. As it cools down, the vapor pressure goes down. And vapor pressure is independent of atmospheric pressure. Whether you're at sea level or up at Denver, vapor pressure is the same. Desflurane, it's about 660 or 670, the highest, and we have to have a special vaporizer to deliver it. Isoflurane next at 240 millimeters of mercury, and sevoflurane is the least at 160 millimeters of mercury, and this is expressed at 20 degrees. We also need to know MAC because the physiologic effects like hypotension that occur are often increased the more we deliver of a volatile anesthetic. Isoflurane's MAC about 1.2%, Sevo about 2%, and Des 6%. So let's give an example here. If we poured isoflurane liquid in a sevoflurane vaporizer, and we set the sevoflurane vaporizer at 4%, thinking that we were delivering about 2 MAC of sevoflurane. The problem is that the vapor pressure of isoflurane is greater than Sevo, so you're going to deliver more than 4%, and this would actually be greater than 3 MAC of iso instead of our expected 2 MAC of sevoflurane, and you would be overdosing the patient. If we could pour Des in an isoflurane vaporizer, if that was possible, the high vapor pressure of desflurane would result in a rapid and very high overdose. And again, the high vapor pressure of desflurane is the reason why we have to have that special desflurane vaporizer, which heats it to 39 degrees and has a 2 atmospheres around it in its own controlled environment. The next gap in knowledge was from the IT 2018, and it is our keyword related to how much volatile anesthetic can be in the ambient air around us and still be in accordance with National Institute of Occupational and Safety and Health guidelines. The gap in knowledge was that according to this NIOSH, the recommended maximum level for volatile anesthetics in the ambient air of the operating room is 2 parts per million. That is, iso, des, or sevo, we're not supposed to have more than 2 parts per million in the air around us. If a volatile and nitrous are combined together, it is reduced to 0.5 parts per million of the volatile and 25 parts per million of nitrous oxide. This 2 parts per million that comes from the National Institute of Occupational and Safety and Health is just a guideline because there is no, quote, safe level of exposure that has been determined, and therefore this was a very low level of ability to detect, and they couldn't detect lower than that at the time that this was determined, so they just said, okay, we're going to make 2 parts per million the lowest because it's the lowest level detectable. If you can smell a volatile anesthetic in the room, it is in much higher concentrations than 2 parts per million. The next topic is blood gas coefficients, and the blood gas coefficient or blood gas solubilities are shown in the graphic on the far right, starting with nitrous oxide at the top, 0.47, but of our volatile anesthetics, desflurane is the least soluble, followed by sevoflurane at 0.68 and isoflurane at 1.4, and halothane historically was very soluble in blood. The reason why nitrous oxide has a faster FA over FI than does desflurane is because of the concentration effect. That is, if we were delivering 6% nitrous oxide and 6% desflurane, the blood gas solubility of desflurane should make a faster onset because it has lower blood gas solubility. But we don't deliver 6% nitrous oxide, it's usually maybe 60%. And that concentration effect results in a faster onset of nitrous oxide despite its blood gas solubility being slightly higher than desflurane. Blood gas solubility is proportional to lipid solubility, which is proportional to potency, and the more soluble it is, the slower onset of the anesthetic state. So if we want to increase the onset of our anesthetic state or increase the rise of alveolar over inspired concentration, we can choose a low blood gas solubility agent. Desflurane would be faster than Sevo than iso. And if we ventilate the patient rapidly to try to speed the onset, the soluble agents tend to be affected more than the insoluble agents. A low cardiac output increases the FA over FI, and things that decrease the onset of the anesthetic state, things like a low blood gas solubility, halothane and iso are slower onset than Des and Sevo. A high cardiac output, very anxious patient, Soluble agents like halothane and isoflurane would be affected more than would DES and SIVO. If you happen to intubate a patient and the tube went down too far, 26, 27, 28 depth, and you had a mainstem intubation, you would be delivering anesthetic to only one lung. That would be a huge shunt, and you would reduce the onset of the anesthetic state, and this tends to affect the insoluble agents like desflurane more than the soluble agents like isoflurane. The next key word is carbon monoxide and CO2 absorbent, and desflurane and isoflurane are broken down into that dry CO2 absorber to carbon monoxide, and desflurane is the one that we normally associate with carbon monoxide formation. In general, the metabolism of desflurane is very small. In fact, halothane historically was metabolized at about 20% of the molecules, sevoflurane at about 2 to 5%, isoflurane at about 0.2%, and desflurane about 0.02%. And nitrous oxide very little, and xenon none. Now, if carbon monoxide is formed, the SpO2 monitor, our pulse oximeter, will not pick that up because carboxyhemoglobin absorbs the same as oxyhemoglobin. We need a co-oximeter or a blood gas sent off to be able to measure it. Remember, sevoflurane in a dry or moist CO2 absorber can form compound A. That halothane is associated with that immunologic injury to the liver. And that fluoride ion can be a breakdown product of volatile anesthetics, with sevoflurane being metabolized the most of SIVO and ISO and DES, about 2%. And fluoride ion levels can go up, but it doesn't cause high output renal failure like historically methoxyfluorine used to. As we pointed out earlier, the recommendations for trace gas in the ambient air around us is 2 parts per million or less of a halogenated agent, SIVO, ISO, or DES, when it's being administered. And when a halogenated agent is being administered with nitrous oxide, it is dropped to recommendation to 0.5 parts per million and nitrous oxide to 25 parts per million. The next key word is stages of anesthesia. Stage 2 we call the excitement stage, when you're doing an inhalational induction with sevoflurane in a child and they start to struggle with you, and their pupils are changing and their eyes are looking different directions, one eye one way, one eye the other way. We call that the excitement stage. Surgical depth anesthesia, stage 3. And it's important to realize that these stages of anesthesia are really based on historical use of drip ether and the effects of such, and we often take the patient straight from the awake state to stage 3 with a bolus of propofol, for example, and avoid the stage 2. The graphic on the far right shows stage 2 being the excitement stage, where the pupils are dilated, there is irregular and fast pulse, the blood pressure is up, excited patient, and then they slip into, as they go deeper, into stage 3 or surgical depth anesthesia, where there's regular respiration, steady and slow pulse, and normal blood pressure. If we go into stage 4, the brainstem is anesthetized, and we can get very hypotensive, and respiratory inhibition can occur, and the patient could die with an overdose. Glycopyrrolate side effects is the next key word. Glycopyrrolate being a quaternary amine, that is NH4+, as opposed to a tertiary amine, which is NH3, does not cross the blood-brain barrier. It's ionized. Atropine, scopolamine do cross the blood-brain barrier and can cause central anticholinergic syndrome. Now, these tertiary amines, atropine and scopolamine, can also result in dilated pupils. We're going to avoid these drugs like scopolamine patch or intravenous atropine in patients with acute angle closure glaucoma. If they have angle closure glaucoma, if you cause the iris to become dilated, it's like a curtain folding back against the corners of the eyeball where the drainage system is, the canal of Schell. And if the drainage system is impaired even more by this curtain of the iris being pulled back against it, the glaucoma pressures in the eye can go up dramatically, and you can precipitate acute angle closure glaucoma. So don't use anticholinergics in someone with angle closure glaucoma. The central anticholinergic syndrome, the tertiary amines cross the blood-brain barrier, and confusion, somnolence, and sedation can result. Using Scopolamine in an elderly patient would be an example. This central anticholinergic syndrome can be reversed with physostigmine, which crosses the blood-brain barrier, centrally acting, inhibits anticholinesterase, and raises acetylcholine levels. Other side effects of glycopyrrolate specifically are they can speed up the heart rate, suppress sweating, and body temperature can go up. The lower esophageal sphincter actually relaxes with anticholinergic agents, and glycopyrrolate is a bronchodilator and can increase dead space. So glycopyrrolate doesn't have the central nervous system effects per se, but it can affect heart rate, sweating, lower esophageal sphincter relaxation, and dead space. The next key word is postoperative nausea and treatment of such. Let's look at the classes of drugs first on the top left. We can use prokinetic drugs like metoclopramide or Reglan, which really, its main effect is to have the stomach empty more. The lower esophageal sphincter tone goes up, the stomach contracts, the pylorus opens, and we empty more from the stomach. So we use Reglan, especially like in diabetic patients with autonomic insufficiency, to help them empty. It is a dopamine receptor is where it's acting, and Reglan would not be used in a patient with Parkinson's disease, for example. Serotonin antagonists on ondansetron, 5-HT3 receptor, antimuscarinics like atropine and scopolamine act at M receptors, antihistamines, histamine receptors. We have the new drug aprepitant, which is a neurokinin antagonist, and then we have dexamethasone using a propofol-based anesthetic, and even midazolam as an anti-anxiety treatment in the preoperative period tends to reduce postoperative nausea. Let's look at the top right, adult risk factors versus children risk factors for postoperative nausea. Adult risk factors, things like a person who has a history of motion sickness, they're female, they don't smoke, they're going to be using opioids postoperatively, and they're having a GYN surgery. That would be a very high-risk patient, laparoscopic GYN surgery, for example. While children, long surgeries, not the really young, but the greater than 3-year-old, the kid that's having eye surgery, they're going to pull on the eye muscles, they're going to vomit afterwards. That's a high risk. And a relative with postoperative nausea, vomiting, or themselves with a history of postoperative vomiting. These are the risk factors, adult versus children, and if they're medium risk factors, we say, I'm going to pick 1 or 2 interventions. High, we're going to pick more than 2 interventions and use a multimodal approach, including things like propofol, dexamethasone, 5-HT3 antagonists, and other drugs. Now, what do we do if our treatment options fail the patients in the recovery room? If our prophylaxis fails, use an antiemetic from a different class. Don't just repeat the same drug that you gave just a couple hours before. Readminister only if it's been more than 6 hours after being in the recovery room after the drug has been given, and don't readminister dexamethasone or scopolamine. They're long-acting, and there's no need to repeat it, at least according to our guidelines. And the bottom left of this slide shows some potential problems with antiemetic agents. QT prolongation with droperidol and ondansetron. Parkinson's disease, we're going to avoid dopamine blockers like droperidol and compazine. Angle closure glaucoma, we're going to avoid the anticholinergics like scopolamine. Someone who has old age or dementia, scopolamine would not be a great idea. And diabetic patients, just remember that dexamethasone can increase their blood sugar. Furosemide side effects. What are some side effects of Lasix? It can cause excretion of many ions, including sodium, calcium, and magnesium, and low levels, and causes a hypotonic urine because a lot of water is excreted. When you give Lasix, one of the first things that occurs is venodilation, even before the diuresis that occurs. So it reduces preload, and therefore it's a good treatment for congestive heart failure. Its onset is in about 5 minutes, it maxes at 20 to 60 minutes, and persists for several hours. And its action is at the thick ascending limb and causes inhibition of resorption of sodium and chloride. So the side effects of Lasix include excretion of ions, venodilation, and someone who's on it for an extended period of time can get a contraction alkalosis. The classic, someone comes down from the ICU who's been on high doses of Lasix, and you look at their blood gas, and there is a high bicarbonate, and you say, why are they so alkalotic? And then you realize that they have been on Lasix for an extended period of time. They also lose potassium. Not uncommonly, people on diuretic medications come into the perioperative period with potassiums of like 2.8, 2.93, 3.1, and we go, what do we do with this? Lasix causes hypokalemia. It also causes hearing loss and hyperuricemia. And our next topic is diuretics mechanism of action and Diamox or acetazolamide, its effects on ion concentration. Let's look at mechanism of action first. They're color-coded. Thiazides work at the distal convoluted tubule, and some of the side effects of them include hypercalcemia and hyperuricemia. Diamox works at the, in blue, the proximal tubule, inhibits carbonic anhydrase such that you pee bicarbonate. And if you pee bicarbonate and have this renal loss of bicarbonate, you're going to have a metabolic acidosis. Bicarbonate loss in this metabolic acidosis is something that we can see in patients who are taking Diamox, for example, for glaucoma, or possibly someone who's taking it for preparing to go to high altitude as prophylaxis. So carbonic anhydrase inhibitor, Diamox, bicarbonate loss in the urine. And spironolactone in purple here is an aldosterone antagonist, distal tubule, inhibits sodium and potassium effects at that distal tubule, and they're considered potassium-sparing diuretics, such that one of the side effects is that you can cause hyperkalemia, because normally aldosterone comes to that distal tubule and causes sodium to be reabsorbed and potassium to be excreted. And if you antagonize our aldosterone, hyperkalemia can occur. Medications that prolong QT interval, QT corrected greater than about 460 milliseconds, some places say 440 or 450. We say that that's a prolonged QT interval. Women tend to have a little bit longer QT interval, and at the top right is a graphic showing where the QT interval is measured from. Acquired versus congenital are the two types of prolonged QT interval. Acquired is medication related, and that was the key word. What medications prolong the QT interval? Amiodarone, sotalol, methadone, droperidol, Haldol, ondansetron are antiemetics, and the opioid methadone, as well as some antidysrhythmics like amiodarone, prolong it. Congenitally, there are diseases, Romano-Ward and others, that have a long QT syndrome, a problem with the calcium channels maybe, or sodium channels, but there's cardiac ion channels that are affected, and these patients with prolonged QT interval can have syncope and sudden death. They're usually on beta blockers and may even have an ICD in place. The risk is that as the QT interval goes up, you can get an R on T and go into polymorphic ventricular tachycardia, which is shown in the graphic on the bottom right. This polymorphic ventricular tachycardia can come and go. That's called torsades de pointes. And the treatment for it is to avoid these drugs, first of all, but magnesium can be used, and to avoid adrenergic stimulation. And these patients are usually on beta blockers, and we should continue these beta blockers, very important to do in patients with prolonged QT interval. Inhaled anesthetics actually prolong the QT, but it appears to be okay if a patient's already on beta blockers to use an inhaled anesthetic in the perioperative period, but we often use a TIVA in these patients. Correct potassium and magnesium problems and avoid those drugs like antiemetics that increase the QT interval, and realize that they are at risk, these patients with prolonged QT interval, for dysrhythmias like torsades. Last slide. Of a key word is nerve gas treatment, and classically the farmer who's exposed to a pesticide, organophosphates, or a soldier in the field who's exposed to a nerve gas like sarin is the patients that will have toxicity from these drugs that inhibit acetylcholinesterase. So if you have a nerve gas like sarin that is inhibiting acetylcholinesterase, you're going to build up acetylcholine. If you build up acetylcholine, it can act at muscarinic sites, shown on the bottom right graphic, and result in things like the sludge syndrome of salivation, lacrimation, urination, diaphoresis, GI upset, and emesis. And the pupils are small, and you have major bronchoconstriction and bradycardia. They can act at nicotinic sites, raising acetylcholine levels there and causing fasciculations, kind of like succinylcholine does, and eventually muscle weakness and respiratory paralysis. So you can see why a patient exposed to sarin nerve gas would die from respiratory paralysis and bronchoconstriction and bradycardia. The treatment for this cholinergic crisis is, if they've been exposed, give them atropine. Atropine blocks acetylcholine effects. Another treatment is 2-pralidoxime, and that reactivates the acetylcholinesterase enzyme. However, this is controversial. Atropine is the classic treatment. Interestingly, if a soldier is going into battle where they're going to be at high risk for exposure to sarin nerve gas, prophylaxis with pridostigmine apparently is occasionally used. Pridostigmine causes reversible inhibition of the acetylcholinesterase active sites, protecting them from irreversible inhibition by that sarin nerve gas. It doesn't cross the blood-brain barrier, and if a patient was exposed, even after they've been prophylactically treated with pridostigmine and they get sarin nerve gas exposure, you're going to still give them atropine and probably 2-PAM for their treatment. This ends our keyword review on pharmacologic topics, Keywords 2018. Good luck. This is pictures from the Oregon and California coast from a bike trip I took from Seattle to San Francisco, 1,000 miles with my tent and sleeping bag in September of 2008. I hope you have a great day.